historian because last night he filled me in on a little bit more of your history as well. So the only thing is I have to apologize. In exchange for this wonderful invitation, I brought rain with me because I come from Galway on the west coast of Ireland, and Galway is known for oysters, Guinness, and rain. And I'm sorry I brought the rain with me, but I hope when I leave it, it goes away and you get some summer. I've been tasked to talk about this. I'm bringing up the rear on this conference, so well done to everyone who's kind of stayed the course. The day, it must be very tiring getting all this information in. It's just like this is coming to the end of the day. The tricuspid valve was known to be the forgotten valve, but I think more recently we've been paying more attention to it and how important this valve is in our hearts. And I think also this has stimulated, besides just surgery, this has stimulated advancements in more minimally invasive or interventional type of treatments for tricuspid valve disease. But that's not what I've been asked to talk about. I've been asked to talk about timing. And as the day is coming to an end, I've got a long answer and a short answer. The long answer is we don't really know when the right time is, and it's still controversial. But I suppose I have to pay for my supper, so I'm going to give you the long version. I have no disclosures related to this presentation. This is a spectrum of disease, but seeing that tricuspid regurgitation really is the predominant problem that we see in the tricuspid valve, I'll focus on that, and we might just mention some of the other things. So this is just the etiologies there. The primary tricuspid regurgitation is predominantly a leaflet problem, and the incidence ranges between 10 to 25%, and the remaining 75 to 90% are secondary. And of the secondary, I think the key thing is left heart disease. And I think if you see someone with severe tricuspid regurgitation, first question you have to ask yourself is there left-sided disease? Because it can be missed in some situations. And I've had some patients where I've asked to go back to the echocardiogram and have a good look at it or repeat it. And more often than not, we found that there may be very, very eccentric mitral regurgitation that's probably causing this. So hunt for left-sided disease, and we'll go through that a little bit in the guidelines. But if it's truly primary TR, it evolves slowly, but it is, and I'll show you some data, it's associated with a high mortality in comparison with the general population. And the incidence of heart failure or severe symptoms was over half in the number of patients that were looked at in a 10-year timeline who were asymptomatic initially. And this is correlated very strongly with RV enlargement. And I think this kind of merges very well with the previous talk, where I think one of the problems we've had is with echocardiography is actually looking at RV function. And I think CineMR is probably going to be I think it's currently the gold standard for looking at the right side of the heart. And RV dysfunction, severity of the tricuspid regurgitation, increasing pulmonary artery pressures are independent predictors of survival. And this is a key thing, up to 50% of patients who have mitral valve surgery for functional ischemic mitral regurgitation have moderate or severe TR. And the late incidence of this develops in approximately 25 to 30% of patients. In fact, in some studies, it's as high as 50%. And this increases with time after the previous left heart surgery. And one of the main problems with this is that if we miss the boat in fixing this at the time, once you get to a point where you've kind of looked at this patient and looked at them, and they're getting bad RV function, getting end organ dysfunction, it's too late to deal with these people. And the mortality from surgery is high, and these patients are not in great shape. So the key thing really in timing is this kind of not sitting and waiting, and that's really the bottom line here, but we'll go through some of the data regarding this. The evolution of it is unpredictable, but definitely associated with reduced survival. And the severity, isolated secondary TR is less frequent, and the prognosis strongly depends on TR severity. Again, in the 10-year survival is 38 versus 70% respectively. I just put together this, but I think I should really move the pulmonary hypertension across, because it's really pulmonary hypertension that impacts on the RV over time. And it's really the RV dysfunction and dilatation that results in annular the annulus dilating, and that contributes to progression. They are a group of patients with pacemaker leads that, if you can't find anything else, it's usually the pacemaker lead when you go in and fix this, and you find that the pacemaker leads are actually pulling down on the posterior leaflet or caught in the chordae and causing this. And when you reposition them and you put a ring in, and these guys get better. So just to remember that pacemaker leads can cause this too, and it's actually something that's quite easily fixable. This is just a pathophysiology, but the key thing here is that you're getting, with left-sided disease, with rheumatic heart disease, you can get organic tricuspid disease as well, but it's always associated with left-sided mitral valve disease. But it's then MS and MR that results in left-sided pressures going up, pulmonary hypertension, and then RV problems and dilatation. One of the things that I noticed that was interesting in some of the TAVI literature is that they're discovering that even in severe aortic stenosis in patients who are undergoing TAVI, there's a significant proportion of patients that have tricuspid regurgitation as well. And they did find that in about 30 to 40% of these patients, the TR gets better when they fix the aortic stenosis. I didn't find much in that sense in the surgical literature over that. In the pathophysiology, this is what we see when we open the right atrium from a surgical point of view. The tricuspid valve is facing you, and that's pretty much what you see. And it's interesting. The valve is not in one plane. It's just like the mitral valve. But what happens is, as the anteroposterior part of the annulus dilates, it becomes flattened out and becomes more planar. And for example, I use a McCarthy ring when I use a ring to repair these. And if you look at that ring, it's a three-dimensional ring. It's not actually flat. And in fact, when you implant it, you see it actually rotating, not only reducing the annulus, but also rotating it somewhat back into the position it should be. And that's why it works well. And I think we've realized, I think someone was making a point about three-dimensional disease, that our valves are three-dimensional rather than two-dimensional. And certainly in repairing this valve, you're restoring it from a more planar point of view to a non-planar three-dimensional shape when you do these repairs. This is some data from Shin and Schaff from the Mayo Clinic. And basically what they reported was that in a population of patients with flail leaflets, so this is primary TR, they found that they matched this in the US population, and they found that there was an excess mortality of 4.5% in the overall population with flail leaflets. But if you took away patients with associated disease causing symptoms, it was still pretty high at 3.8% annually. And in panel B over there, it just shows that the incidence of combined endpoints, so that's heart failure, death, new onset atrial fibrillation, cardiac surgery, that there was a very significant, over 10 years, there was a very high mortality rate in these patients. And this is also from the same group that looked at the similar factors. And if you look at this onset of new atrial fibrillation, which was 2.8% yearly, class 3 or 4 symptoms or congestive heart failure was 4.4%, and composite endpoints, again, of heart failure, new onset atrial fibrillation, surgery in the tricuspid valve, or death, it was 6.5% yearly. So it is a very significant problem. So how do we evaluate the tricuspid valve? I won't go through this because the experts have talked already, but just from a surgical point of view, these are some of the things that we look at in trying to make decisions together with our cardiology colleagues as to whether we're going to deal surgically with these patients, which at the moment is really the only way we can deal with these patients in trying to fix this problem. In primary TR, we look at the actual structure of the leaflets. In secondary, we look at annular dilatation, because in the guidelines, there's some recommendations there as to how dilated the annulus should be if you're considering fixing it. RV dimensions and function, evaluation of the severity of the TR, pulmonary artery systolic pressure. And as I mentioned earlier on, the right ventricular dimensions and functions there are limitations to the current indices, and I think CMR is going to actually help us more in being more accurate with the determination of RV function and dimensions. The problem is it's an expensive modality. It requires quite a lot of expertise. Not every center has them, and you're not going to be able to put all these patients through an MRI machine. So that's going to be difficult. We should also look for associated lesions, particularly on the left side, and sometimes they're subtle and underestimated. Obviously, you have to look at LV function as well, and then right heart catheterization. In our center, everyone gets a right heart cath if we are considering fixing, especially if they've reported pulmonary hypertension or problems on the right-hand side. They routinely get a right heart cath for more evaluation and more information for us to help to make a decision. I've got this from the guidelines, the ESC guidelines. The key thing here in isolated pulmonary, and I'll go through the actual guidelines themselves very quickly, but the key thing is to rule out left-sided dysfunction. Once you've done that, you're looking at the severity of the regurgitation. And if you're symptomatic, this is where there's a class 1 indication. And I have to say that, like a lot of things in cardiac surgery, the level of evidence is C in all this. We don't actually have good data for all these recommendations. So the level of the evidence is C, but it's a class 1 indication if you've got severe TR and symptomatic. And then it really comes down to whether you've got RV dysfunction or not. And if you do, if you've got dilatation or dysfunction, there is a class 2 indication to operate. On the right-hand side, it's a little more hazy. It is very hazy, actually. And there's quite a bit of uncertainty in non-severe primary tricuspid regurgitation. With secondary, again, you identify the left-sided lesion, and then if you're going to have surgery on the mitral valve or sometimes on the aortic valve, if it's severe, it's a class 1 indication. And then for non-severe tricuspid regurgitation, you're really looking at the annulus, and that's why I mentioned the size of the annulus. If it's equal or more than 40 millimeters or 21 millimeters per meter squared, there's an indication to operate. Or you've had recent signs of right heart failure, or severe pulmonary hypertension, there's an indication to operate on these patients. If you've got severe secondary TR that's not associated with left-sided surgery, if you're symptomatic or there's a problem with your right heart, it's a class 2 indication to operate on these patients. I think one of the problems here sometimes is that if you've got left-sided valvular problems or left-sided symptoms, it may be difficult to differentiate this from right-sided symptoms in some situations if you don't examine the patient fully, but even then it's sometimes difficult. Or if they have concomitant other diseases like COPD, it may be very difficult to actually determine whether or not there's significant right heart dysfunction from that point of view. So the question was, when do we operate in patients? The timing. Really, it seems to me, and looking at all this, that it's vague, but we've got some guidelines for it. But the key thing is that if you think that the RV is giving trouble, you shouldn't wait in these patients. I think that's the bottom line here. Because once you go down that road and you start to get liver congestion and problems with your renal impairment from this, the mortality goes up and the benefit is lost in these patients. And as I pointed out earlier on, there's limited data and the data is heterogeneous, so it's difficult to do it. So kind of coming to the end of this, just the 2 class 1 indications there. You've got in primary tricuspid regurgitation, if you've got severe primary tricuspid regurgitation and you're undergoing left-sided valve surgery, you should operate on the tricuspid valve. If you're symptomatic without severe RV dysfunction, isolated tricuspid regurgitation is class 1 indication. And then 2A, moderate, and then if you've got RV problems. That's the key points here. I think the table says it all, really. This is just a kind of a summary of that. So in severe primary tricuspid regurgitation, if you're symptomatic, or if you're asymptomatic, if you've got right-sided problems, or you've been watching the right side and it's beginning to decline, you should operate and avoid problems with the RV. In secondary tricuspid regurgitation, the class 1 indication is if you've got severe tricuspid regurgitation and you're having left-sided surgery. There's no doubt about that. I think you should do it. If you've got less than severe, but you have a dilated annulus, you should consider, it's a 2, so you should consider operating on these patients at the same time. And if you've got mild to moderate, even without annular dilatation, but you've got previous symptoms of right heart failure that's been documented, there's a 2B indication for that. And then this last one, 2A, is if you've had previous left-sided surgery, where you may have missed the boat on these patients, or they've developed progressive tricuspid regurgitation over time, you shouldn't wait until they get severe LV dysfunction. You shouldn't wait until they get severe pulmonary hypertension. You need to keep an eye on these patients, and you should consider operating on them earlier rather than later. So basically, I don't know, I could poll the surgeons here. I was trained to go through the right side across the septum into the left when I'm doing mitral valve surgery. So I see the tricuspid valve all the time. Where I trained, my boss was very, very liberal with treating the tricuspid valve, even back then when I was training. We used to put annuloplasties in donor hearts before we transplanted them. So we were very used to using stitch annuloplasties, and we put rings if they were more severe. So I think the recommendation here is don't be worried. There isn't an increased risk if you're doing a left-sided operation to actually do something to the right side. Tyron David has said in one of his editorials that their policy, if they've got mild to moderate TR with no pulmonary hypertension, they're quite happy to do a bicuspidization or suture type annuloplasty, which takes you 10 or 15 minutes to do. But he says that in 3+ or greater, and I don't think anyone would argue with that, and if you have pulmonary hypertension, then you should be putting a ring into these patients. And then just to recap, with that last group, reoperation on the tricuspid valve in patients after valve surgery carries a high risk, and therefore you really should be keeping a close eye on these patients. And if there's anything that points to the fact that they're getting progressive tricuspid regurgitation, or they're getting problems with the RV, you should consider operating on these patients early, because the mortality is high if you wait too long. And also consider going through a right thoracotomy, because there is some evidence that there's a lower risk, mortality risk, if you go through the right side in a redo on these patients. Just a very quick word about tricuspid stenosis. I probably see it once every 2 or 3 years. It's most often as a result of rheumatic heart disease, and is always associated then with mitral valve disease. And then there's some causes there. Most of them are rare. Just evaluate it carefully. I think a lot of the time when we do echocardiograms, we don't tend to look at the right side very often, but there are times when you should just kind of clue yourself to look at the right side as well, or maybe ask them to get better views of the right side. Make sure you don't miss it. It's widely accepted that clinically significant stenosis is if you have a gradient of over 5 millimeters of mercury at normal heart rates. And basically the two class 1 indications here with level of evidence C is symptomatic patients with severe stenosis and severe tricuspid stenosis going left-sided intervention. I wasn't asked to talk about prosthesis and things like that, but most of the time you should try to repair these valves. But most people would prefer a bioprosthetic valve because of risks of thrombosis with mechanical valves. And also in the tricuspid position, these bioprosthetic valves have good durability compared to the left side. I'd like to thank you very much for listening to me at this hour of the day. That's our hospital over there, an aerial view. Please feel free to drop me an email if you want to chat about anything. And we are the European capital of culture in 2020. So if you want to have fun and enjoy visiting a new place, come over to Galway. That's the seafront over there. That's our cathedral. That's the university where I also do a lot of research work in. And that's the main square there. Thank you.
Thank you very much. A wonderful presentation. Any question from the audience? I would like to ask one surgical question. Do you have any experience with the core matrix, with that technique that making a new tricuspid valves completely made of? No?
No. My experience is limited to different types of annuloplasty techniques. I have patched tricuspid valve leaflets in endocarditis. Sometimes we get quite a few. We have a reasonable number of IV drug abusers, so kind of leaflet repairs and things, but not with. I haven't used core matrix to do it, and fairly simple patch repair, shaving and patch repairs. I've replaced cord A maybe 2 or 3 patients, but not a lot.
Okay, thank you. It seems to this promising technique, at least to destroy the valves when you cannot repair.
Absolutely, I think so. And I think it's better than probably putting even a bioprosthetic valve in. I think trying to repair the valve is probably the best thing to do. It's just that we don't often get that much volume of that coming along to really look at results.
What is your opinion about the like moderate TR and pulmonary hypertension in the patient that are undergoing like mitral surgery or left side heart surgery?
I don't
Should
know.
we intervene or not?
Maybe you know, people. I think you should intervene. My feeling is that I don't think you lose anything by intervening in these patients. It's often nice to, well, moderate pulmonary hypertension is fine. It's often nice to know, you know, I think the difficulty comes sometimes when you're not sure the pulmonary hypertension is going to be reversible when you fix the left side. But I still think that you should deal with the right side, because if you don't, it's going to progress over time, either way. I think in the past people used to say, oh, you know, if it's moderate and we fix the left side, it'll get better. Data showing that it isn't. It doesn't get better. And it doesn't get better in about 50 or 60% of patients, quite a lot. So I think you should do something to the right side. I think if you've got moderate pulmonary hypertension, I think you should put a ring in. That's just what I feel. I think there's some data to support it. I think if you don't have pulmonary hypertension, a quick suture annuloplasty I think would probably be okay. Maybe some people might disagree with me, but that's what I would do.
Okay. And is there a role for MRI in like where you are watching your patients that are not yet ready, or when you're making
I think listening
decision?
to the previous talk, listening to the previous talk, I think, and even Jerry might say that. I think it probably is the gold standard now for looking at the right ventricle. The problem is it's expensive. You know, you may not be able to put these patients through the MRI machine in time to keep an eye on them. There's huge demand for soft tissue and all sorts of other things with that. I mean, in our center, we've got 2 MRI machines on site, and we have another 2 on the other hospital site, but they're flat out. Yeah, no.
We've got almost complete access to MRI, mainly through a research and a clinical scanner, but we're talking about expense, but there's no issue about doing a right heart cath or doing coronary angiography or doing stenting. MRI is not that expensive compared to invasive investigation, and for me, if there is doubt about surgical intervention, which is a high-risk procedure where the patient may not get any benefit or be subjected to a major thing, then for me, doing MRI is by far the lesser evil. I do
No, I absolutely agree with you. I think it's just logistics. I think it's just logistics. I think in a lot of centers it's just logistics. How many patients have trouble lying in an MRI machine for 45 minutes? That's the other thing. If they're symptomatic, they may not be able to lie down for 45 minutes. Some patients are claustrophobic. And the noise. Have you been in an MRI machine? I have.
I literally use station. I need everybody's a great example.
Yeah. No, but I agree with you, Jerry. I think
You can do it a lot quicker. You know, if your primary thing is volumetric and reduction volume or fraction, you know, that could be 20 minutes. And as previously spoke, the accelerated techniques are coming through that you'll be able to do a whole LV coverage with real-time imaging. And in our hands, we're getting results that are very similar to doing a stack of breath-hold images that takes 7 or 8 minutes. So, but, you know.
No, but I think you're right. I think if it hinges on whether we're going to decide to operate on a patient or not, I think you're right. You need to use the imaging modality that's, yeah.
I have 2 questions. Because there is this kind of trend now to both the guidelines that they use a liberal use of
Yes.
annuloplasty in the guidelines, European guidelines, and David Adams is pushing his papers, you know, just put ring on everybody, on the rest. And I think it's a bit crazy. What is your opinion? If you have a patient like 45 millimeter rate, about this 40
Yeah.
millimeter, by the way, try to trace where it's coming from, because I tried, it's very difficult to find, and it's not coming from the surgery anyway. But if you have 45 and mild or none for a hospital, doing mitral, you put ring or put ring.
Yeah.
What's your opinion?
Yeah. Personally,
Yeah.
I would actually put if mild to mod, no,
Yeah, you have
mild.
No, it's not moderate. It's
Okay.
mild.
And pulmonary hypertension?
No.
Okay. Yeah.
But it's 45 or
Yeah.
more.
I think based on annular size, I'd use a ring. I wouldn't suture annuloplasty. I would use a ring.
Okay, and another question is, because
But let me just point out that David Adams, right, is pushing that because he's got a disclosure. He's got a ring on the market. So
Another question is because in the future there is a high recurrence rate of tricuspid.
yes, there's no doubt about that.
The trouble is, do we do it right actually? When we come to operating on someone who's got a severe tricuspid with pulmonary hypertension, then we do put a ring and we get a high recurrence rate.
Yeah, I know.
So
I know.
what do we do about it?
I didn't cover that because that wasn't really what I was asked to talk to, because that's a very good point. And if you look at all this, the recurrence rates in most studies, even if you do something to the tricuspid, and that's where the repair technique comes in, the failure rates with suture annuloplasties are higher on average. That's why I think you've got to be careful when you use suture annuloplasties compared to rings. But even rings have a significant failure rate over time. They do, absolutely. About 37, there was a study, I can't remember whose study it was, but when I had been reading up on this, it's about 30% over 5 years, the recurrence. So over 5 years. So it's actually very high, even with a ring. And we don't have anything else except a ring. So, and I think last night,
Because that is as drainage to pipe down the but it's bigger surgery.
yes, but that's why I think, and this wasn't also part of the discussion, but I also think that percutaneous techniques might be the answer to this, where we may have chances to go back and, I don't know, because these are still in their infancy, but that might be the way, because reoperative, I think even if you go back in and redo the surgery, these patients have a high risk for mortality and they're going to fail. There's something about the tricuspid dilatation that even with a ring in, it doesn't have the same durability of repair that mitral valve rings do. And I don't really know why. You think of, thank you.
Prior to introduce the